Hello, everyone, and welcome to this new lecture of the series on fluid, electrolyte, and acid-base disorders. If you haven't done so already, please subscribe to the channel and like the videos. This series is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. You can find it on Amazon. Please follow the link below. It's available as an ebook and hardcover. Both are in full color, and also there is a paperback edition. So welcome again to lecture 50. We are still on chapter 7, hypophosphatemia and hyperphosphatemia. Today we are going to start our discussion of hypophosphatemia. What about drug-mediated hypophosphatemia? Usually here we have multiple mechanisms. So some medications increase phosphate excretion in the urine, like diuretics, for example, hydrochlorothiazide, corticosteroids, imatinib. Another diuretic would be like a carbonic anhydrase inhibitor like acetazolamide. Other medications in this category include theophylline, estrogen, acyclovir. So here you have increased excretion of phosphate in the urine. So that's straightforward. Very important in this category are phosphate binders. So patients with chronic kidney disease, especially when they're on dialysis, we give them phosphate binders. Those binders bind phosphate in the diet, in the meal. If the patient is not eating well and the patient continues to take the phosphate binders, you are going to have hypophosphatemia. So this is why for patients on dialysis, we check phosphate twice a month or at least once a month, and we adjust the dose of the binder or stop the binder altogether if we have hypophosphatemia. Antacids also bind phosphorus like aluminum, calcium, and magnesium. And as a matter of fact, many phosphate binders have magnesium or calcium in them. Aluminum is a very good phosphate binder, but we don't give it to patients with chronic kidney disease, especially when they are on dialysis because of aluminum toxicity. Phenobarbital and phenytoin can cause hypophosphatemia because they cause vitamin D deficiency, so those patients should be on vitamin D. There has been several case reports of intravenous iron causing hypophosphatemia. Now, the mechanism of intravenous iron causing hypophosphatemia is probably elevated FGF23 and low calcitriol level, in addition to direct proximal tubular toxicity. Now, let's talk about genetic causes of hypophosphatemia or familial hypophosphatemia. Now, these causes, granted, are not common at all, but they are important to know, important to recognize, especially for the nephrologist, pediatric endocrinologist, pediatrician, pediatric rheumatologist, etc. So those familial causes, familial hypophosphatemia, can be either due to FGF23 excess or can be independent of FGF23. Let's start with causes related to FGF23 excess. By far, the most common is X-linked hypophosphatemic rickets. So if you want to know one disease in this category, know XLH, X-linked hypophosphatemic rickets. This is autosomal dominant, and it's responsible for more than 80% of cases of familial hypophosphatemia. So what do we have here? We have loss of function mutations in the PHEX gene, the phosphate regulating gene with homologies to endopeptidases on the X chromosome. Just remember PHEX, with subsequent rise in FGF23 level and renal phosphate wasting. So what we need to remember in X-linked hypophosphatemic rickets, we have high FGF23 level, and when you have high FGF23, you are going to have wasting of phosphate in the urine. That's it, okay? FGF23, like I said a million times, is phosphaturic. Now, FGF23 is going to suppress calcitriol production by the kidneys, so calcitriol is going to be low or possibly normal, so it kind of follows logically. Now, in this disorder, X-linked hypophosphatemic rickets affected children, and it affects children, have impaired growth, we have osteomalacia, we have rickets, We have lower extremity pain, deformity, fatigue, weakness, etc. Interestingly, we have a new medication for this. It's called Berusumab, and it's a recombinant human monoclonal antibody. It is a blocker of the FGF23. So here we have an FGF23 blocker. It was approved by the FDA in 2018 specifically for the treatment of X-linked hypophosphatemic rickets. There are other causes of familial hypophosphatemia that is due to FGF23 excess. Like I said, by far, if you want to remember, one thing is X-linked hypophosphatemic rickets. But there are other disorders where you have also increased FGF23 level. We have autosomal dominant hypophosphatemic rickets. You have autosomal recessive hypophosphatemic rickets, and then you have McCune-Albright syndrome. I'm not going to go into details. You can just look at the slide or look it up in the book. It's unlikely that you will see these disorders unless you specialize in this area. Now, there are causes independent of FGF23, and here we have Fanconi syndrome. So Fanconi syndrome and type 1 proximal renal tubular acidosis, or RTA, we have hyperphosphaturia. We have increased phosphate excretion in the urine, but not just phosphate. We have increased glucose, amino acid, and bicarbonaturia. This is why we have the acidosis. So phosphate, amino acids, and glucose plus bicarb, and this is where you have the acidosis. Now, also it follows that you have renal potassium wasting, and these patients have hypokalemia, occasionally very severe. Some cases are idiopathic, and some cases are due to known genetic disorders like Wilson disease, hereditary fructose intolerance, cystinosis, Lowe syndrome, and Den disease. None of these causes is common. Hereditary hypophosphatemic rickets with hypercalciuria is autosomal recessive disorder. Also, this is an uncommon cause of familial hypophosphatemia. It is FGF23 independent, and here we have mutation for the gene for the NPT2C, and this will result in renal phosphate wasting, but independent of FGF23. FGF23 would be suppressed because you have increased phosphate wasting, so that suppresses FGF23. Now, how do we treat hypophosphatemia? Well, once you diagnose it, it's really not that hard to treat. If the patient is seen in the office, or if the hypophosphatemia is mild and the patient can take oral medications, of course we are going to treat orally, like we do with potassium, like we do with calcium, magnesium, etc. Milk is a good source, 0.9 milligram of phosphate per ml. Now, we can also go with medications like KPhos neutral. KPhos neutral comes in 250 milligram tablets, and each tablet has 8 millimoles of phosphate, 13 millimoles of sodium, and 11 millimoles of potassium. So if you have hyperkalemia, it's going to be a problem, because if we are going to use the usual 4 to 8 tablets a day, that's going to add up. Now, the starting dose is 1 to 2 tablets 3 to 4 times a day. Then you increase it. Usually you cannot increase it because you end up with diarrhea. And when you have diarrhea, you're going to have hypophosphatemia. So this is a vicious circle. So I haven't been able to go higher than 2 tablets 4 times a day. In the intensive care unit, if you have someone who is hospitalized, cannot take oral medications, you have severe symptoms, someone you cannot wean off the vent, you are going to use intravenous phosphate. And sometimes you can use both, PO and intravenous. Now, intravenous phosphate, you only have 2 possibilities, sodium phosphate or potassium phosphate. Now, we dose by millimole, okay? And like I said, with phosphate, it's never going to be milliequivalents or milligrams. So it's always millimoles. So the dose, the usual dose, is 50 millimoles of sodium phosphate or potassium phosphate over 2 hours. And you could give 30 millimoles over 40 hours or over 4 hours, or you can give 45 millimoles over 6 hours, so on and so forth. Usually you're going to give 15 to 30 millimoles, and then you'll check the level again, and then you redose if needed. Now, if the patient has hyperkalemia, we are not going to use potassium phosphate. On the other hand, if the patient has hypokalemia, we are going to use potassium phosphate. The rate of infusions should not exceed 7.5 millimole per hour. That kind of reminds you of potassium when we said the rate should not exceed 10 milliequivalents per hour. And then we monitor phosphate every 12 to 24 hours during IV replacement, and then we redose as needed. I'm going to stop here. See you in the next lecture.